Hey everyone! So today we're going to talk about our clinical assessments. So we've done anthropometrics, we've done biochemical. Here we are in clinical. Next we've got dietary, then environmental, then social. So what is the clinical assessment? Well, part of it is the history, personal history, family history, but it's also the physical exam. And for us, we use the nutrition focused physical exam. And hopefully you've watched the video on the nutrition focused physical exam from the Abbott Nutrition Health Institute. Part of the clinical assessment we actually kind of put into a different category, but it's important to know what medications the person is on. So a note on personal information, things like date of birth, age, but also sex. And when people think of sex, they often think in binary, male, female, but there's actually a spectrum of biological and physical traits characterizing maleness and femaleness. So even sex is a spectrum. There's people who are intersex. Gender is a continuum of socially constructed roles. The important thing here is socially constructed. So while sex is often biological, while sex is biological, gender is social. So it's those socially constructed roles and behaviors associated with men, women, and overall gender spectrum diversity. And then race and ethnicity. Why is this important? Well, there are some genetically linked diseases that are more common in some races and ethnicities than others. But what race and ethnicity really gets at is socioeconomic status most times. Because we come from a society that has historically marginalized non-white races, we see higher rates of all sorts of illnesses within marginalized races. It has nothing to do with their genetics. They're exactly the same as you and I. It has everything to do with their socioeconomic status. And sex and gender can interact with each other to affect disease burden. So, a great example is heart disease. For a long time, heart disease was considered a male disease. Men died from heart disease. And while, yes, many men do die from heart disease is just as prevalent in women as it is in men. However, women are less likely to get treatment for heart disease and are more likely to have a heart attack and not get treatment for it because of gender roles. So you may have heard stories of an aunt or a grandma or someone who had a heart attack and they didn't tell anybody because they didn't want to bother someone. Or because they didn't feel like the symptoms they were experiencing were that bad. So that is how gender can influence someone's disease burden. On the other hand, sex can affect disease burden in more biological or physiological ways. So certain kinds of breast cancer are more aggressive with estrogen. So that is more tied to sex, which is a biological or physiological trait. So a review of the basic tools we have. We have the medical diagnosis. And remember that this is not the same as our nutrition diagnosis. Sorry, my handwriting is terrible. We have their medical chart. We have physician's note, nurse's notes, other health care providers like speech language pathologists, occupational therapy, physical therapy, social workers, pharmacists are a big one. And often, because you're emerging dietitians, you'll have a medical referral. The MD sent the person to you because of something. I will have to erase. So, medical history and surgical history. So, it's pretty important to have the surgical history because we want to know if someone's had a gastric bypass or a pancreectomy. Um, Even small things like, oh, I had surgery on a broken leg, can be useful information, especially for excess weight gain. Oh, maybe that's why they had excess weight gain. They broke their leg, they were unable to perform their normal physical activity. So, in a clinical assessment, the MD will generally note general appearance. They may note that the person is thin, and this isn't the same as how we think of thin in the media. Um, this would have a negative connotation, um, undernourished. Cachectic, obese, and again, this isn't um, a value statement. It is equal to the BMI. Oh, sorry. Let me erase that. Do they have edema? So fluid buildup. Are they yellow or jaundiced? Do they look well nourished, apparently healthy? There's a lot of potential general appearance notes. But for the registered dietitian, usually it has something to do with either thin, cachectic, um, obese, edematous, very similar. Um, the handshake can be very informative. So, is the person's hand cold or warm? Is it clammy or dry? Are you noticing poor perfusion? So, they have very pale extremities, edema. So, examples of the physical exam include the vital signs, the physical or the chief complaint. So, why are they here? Looking at the head, eyes, ears, nose, mouth, looking for things like signs of inflammation, swelling, redness, um, much, much more that we'll go through. Cyanosis, is there a bluish color to the skin? So if someone's skin is kind of blue colored, that may mean that they are um, not taking in enough oxygen. You've probably noticed at the doctor, they check your thyroid glands by palpating your neck. They can also check the lymph nodes in your neck. They may also in your arms. Listen to your breathing and heartbeat. Listen to your abdomen. Uh, they may do some skeletal, muscular skeletal things, reflexes. If they're doing a very more in-depth physical exam, they may check the genitals for hernias or for Tanner staging. They may ask for a fecal sample, but this is really depends on the chief complaint. Um, and then neurological things. Can your eyes follow a light? Um, Grip strength, things like that. So for our vital signs, temperature, obviously, want it to be around 98.6 degrees for an oral temperature. If we're taking a rectal temperature, it's a little bit higher, around 99.6. On blood pressure, we'd like to see around 120 over 80. But uh, when we start seeing things like 140 over 90, that means we're looking at high blood pressure. Heart rate is different between adults and children. Children generally have a faster heart rate, where adults tend to have a little bit slower heart rate. On average, around 60 beats per minute, but anywhere from 55 to 90. And then respiratory rate, around 12 to 20 breaths per minute. Children, going along with a heart rate, also have a higher respiratory rate. So we're going to focus on blood pressure in this lecture. So this was everyone's favorite slide from human physiology. So let's just walk through this first. First thing, let's look at our y-axis. We have volume, and this is probably blood volume. And we have pressure also. Oops, blood pressure. Okay, now let's look at our x. We have isovolumic contraction. Iso meaning same volume. So we're contracting, but we're not changing the volume. We have ejection, exactly what it sounds like. Something is being ejected somewhere else. Then we have isovolumetric relaxation. So again, same volume, isovolumetric, isovolemic, and relaxation, meaning that the muscle is relaxing, this muscle being the heart. We then have rapid inflow, which would be the opposite of ejection, diastasis, and then finally atrial systole. Okay. Let's look at what lines we have going on here. So we have aortic pressure. So think of your aorta, it's a primary artery. We have atrial pressure, so the atria of the heart. We have ventricular pressure, the ventricle of the heart. And then down here in volume, we have ventricular volume. We have the electrocardiogram, and we have the phonocardiogram. Okay, let's keep going. So let's just look at the isometric or isovolumic contraction. So we know that the volume isn't changing. If we look right here, the volume isn't changing. Okay, cool. So this happens when the mitral valve closes and no volume is changing, but we're contracting. So ventricular blood pressure and atrial, well, not yet, ventricular blood pressure is going up. Ventricular pressure. At the end of isovolumic contraction, the aortic valve opens. So when the aortic valve opens, we get ejection. The blood is going from the heart into the aorta. And so we see with ejection, the volume decreases because it's leaving the ventricle. Ventricle volume decreases. If we look at our electrocardiogram, that's where we see our first wave. And once the aortic valve opens, it smooths. On the phonogram, this is when we'll hear our first noise. Okay, let me erase some of this or else it'll get too crazy. Okay, so we've gone isovolumetric contraction. Again, volume same, pressure is increasing. Now we're going to be looking at the isovolumic relaxation. So that starts here. So again, if we go down to our volume, it's low, but it's not changing. The ventricular volume is staying the same because it's isovolumic. We see that our ventricular pressure is dropping, Makes sense, right? Because we open the aortic valve, all of that pressure sent the blood into the aorta, and now after ejection, the pressure is dropping. Right around here, the aortic valve closes because we want it to close when we start relaxing. So aortic valve closes, isovolumic relaxation. If we look down here at atrial pressure is starting to increase. And then if we come down here to our electrocardiogram and phonogram, we are now in the diastolic. So the isovolumic contraction and ejection is the systole. And now we're in diastole, or relax. And then this is contract. Okay, so now we have rapid inflow. Let's look at what is happening to the ventricular volume during rapid inflow. So in rapid inflow, what we see is that the volume in the ventricle is increasing. And that's because the mitral valve opens, the aortic is closed, so now the ventricle is filling with blood. If we look at the ventricular pressure, though, again, the pressure is still low because we're relaxed. And then we have diastasis. So here we see a little bit of a leveling off, though we are increasing the volume a little bit. But this is really the relaxation. We're not seeing a lot of flow. We're seeing ventricular pressure is low, atrial pressure is low, and even aortic pressure is dropping. So everything during diastasis is relaxed. And then next, we have atrial systole. So we've been focused a lot on the ventricular, but now we have the atria contracting. So if we come down here, from here to here, the atrial systole, if we look at the atrial pressure, it begins to go up. We see that the ventricular volume starts to increase because now the atrial pressure is pushing more volume into the ventricle. We're going to see our PQR phase of the electrocardiogram. And after atrial systole, it's going to go back to isovolumetric contraction. And so we're going to hear our first heart sound again because we're back in systole. So atrial systole goes into, this is the isovolumetric contraction right here. And we see that because the volume is the same, but the pressure is increasing. And then we have the aortic valve opening. The pressure continues to increase, but the volume decreases because this is ejection. And then we're back to isovolumetric relaxation. I'm going to call it IV relaxation. Okay. So that's how we go between systole and diastole back to systole. And remember that it's systolic over diastolic. And if you look up here, the highest during systole is 120. And if we look at during relaxation, should be right around 80. So I recommend walking yourself through this just like I did. Look at the words and make sense of them with what you're seeing. And I do recommend covering up each part of this and then going through it. So hopefully you remember from human systems physiology that mean arterial pressure, so the pressure in the artery, is what's driving blood flow, and it's around 90 milligrams of mercury. And so, in order for us to actually get blood into our body, the left ventricle has to increase its pressure greater than 90 milligrams of mercury, millimeters of mercury, excuse me, not milligrams. So we have the heart, and the heart is attached to the artery. So the pressure in this artery is 90. So then to get the blood into the artery, it has to be greater than 90. That's why it goes up to 120. 120 is greater than 90, so the blood will go into the artery. If our heart is unable to overcome the mean arterial pressure, we can't pump blood out of it. Aortic pressure reaches its max, and that is our systolic blood pressure. So at the end of systole, no more blood is entering the aorta. Then the aorta, because it's stretchy, constricts. So it goes kind of like you can think of it as filling up with a bunch of blood. And then because it's stretchy, it's actually going to push this blood forward because it's going to start to even back out. So then the blood starts to go through. And then the pressure in the aorta falls to a minimum, the diastolic. So pulse pressure is our systolic minus diastolic. So for the ideal, it would be 120 minus 80. You can think of that as 12 minus 8, which is 4. 40. On the other hand, mean arterial pressure is diastolic pressure plus 1/3 of pulse pressure. So we can think of that as diastolic plus, and we know that pulse pressure from back here is systolic minus diastolic over 3. So mean arterial pressure is more similar to our diastolic pressure because diastolic lasts longer. Again, go back and look at that figure we just were looking at. And the mean arterial pressure can also be thought of as the cardiac output times the total peripheral pressure. So often you'll see cardiac output as CO. And then total peripheral pressure is basically the rest of the body has some pressure. And so the blood has to overcome the total peripheral pressure by the cardiac output. So MAP is also cardiac output times total peripheral pressure. So we could also say, since this is up here that we just wrote, it's also mean arterial pressure, that means cardiac output times total peripheral resistance is equal to diastolic plus pulse pressure divided by 3. Well, when we think of cardiac output is stroke volume. So the amount of blood times heart rate. How much blood can we pump for every heartbeat is our cardiac output. So then, let me erase this really quick. we can think of this then as stroke volume times heart rate times total peripheral resistance is equal to our diastolic plus systolic minus diastolic divided by 3. Oops. So that's all to say that these are important equations, but think about what these equations mean in terms of the body. So we have to overcome total peripheral pressure, and we do that through stroke volume and heart rate. And that's our mean arterial pressure. Another way of thinking of it is our mean arterial pressure is more similar to our diastolic, but it's the systolic minus the diastolic, 1/3 of that plus the diastolic. Our mean arterial pressure is more than the diastolic because otherwise blood would flow backwards. So then we have to press harder to get the blood out of our heart. So it's also to recall that our cardiovascular system is a huge system, and it depends on the lungs and the kidneys. So the kidneys and the lungs will work to maintain our blood pressure. And how they do that, well, the kidneys can reduce urine output, and that would increase blood volume. And the lungs will try to maintain our pH. So if we look here, this is pulmonary hypertension. So this is hypertension that is related to our lungs. So this is really important in this now like COVID-y world, because people who already have pulmonary arterial hypertension are going to have an even worse time with COVID. But people may also just have heart disease, often the left heart disease. They may have some sort of lung disease or a chronic thromboembolic pulmonary hypertension, or just unclear mechanisms. So let's look at what our normal or recommended blood pressure is. We want our systolic to be below 120 and our diastolic to be below 80. Remember that MAP is normally 90. So people who are at risk for hypertension will have a systolic blood pressure from 120 to 139. Or if we're looking at the American College of Cardiology, it's lower, 120 to 129. And they may even still have a normal diastolic. Hypertension is characterized as a systolic greater than 140 and a diastolic greater than 90. So notice 90 is now near our mean arterial pressure. So our resting blood pressure is near our mean arterial blood pressure. The American College of Cardiology actually has a slightly lower, and they classify hypertension as blood pressure greater than 130. So let's now think about low blood pressure, also known as hypotension. And this is when systolic blood pressure is lower than 90 or diastolic blood pressure is lower than 60. And again, remember that mean arterial pressure is around 90. So if our systolic is lower than 90, we can't overcome the mean arterial pressure, so we are not able to pump blood as effectively. So people often feel lightheaded, weak, dizzy, or even faint. I myself have fainted due to low blood pressure. And it can be caused by not getting enough fluids, blood loss, some medical conditions, and some medications. When I fainted, it was due to a vagal syncope. And normal blood pressure for most adults is a systolic of less than 120 and a diastolic of less than 80. And an elevated blood pressure is between 120 and 129, with a systolic less than 80. And high blood pressure is a systolic greater than 130 and or a diastolic pressure of 80 or higher. So lots of people go about their everyday with high blood pressure. But when is it an emergency? Well, blood pressure over 180 over 120 is a hypertensive emergency or crisis. This often indicates that someone is having some sort of cardiac event. If you ever see a blood pressure this high, seek emergency medical help immediately. So an adult with a 10% risk of developing cardiovascular disease in the next 10 years, or if they have chronic kidney disease, diabetes, coronary artery, the treatment goal is usually a blood pressure around 130 over 80. So often in older adults, the systolic blood pressure is high, but the diastolic can often be under 80. And this is called isolated systolic hypertension, and it's primarily due to the stiffening of the arteries. So this is going to mean that the heart has to pump harder, but it's relaxing at under 180. And this can lead to shortness of breath, lightheadedness when standing too fast, and falls.